Welcome to 2-Minute Anaesthesia and Critical Care, where we make ICU topics simple. Today let's discuss ECMO, Extracorporeal Membrane Oxygenation, one of the most advanced life-supporting techniques in critical care. We'll discuss what it is, the different types, when it's used, the components of the circuit, and the complications. Let's get started. So ECMO stands for Extracorporeal Membrane Oxygenation. It's an advanced cardiopulmonary support modality used in patients with severe, potentially reversible cardiorespiratory failure, unresponsive to conventional therapies. It serves as a bridge of buying time for recovery, decision, advanced interventions, i.e. VAD, or transplantation. There are two basic types of ECMO, Veno-venous VV ECMO and veno-arterial ECMO. Venous ECMO provides only respiratory support. This is where blood is drained from the venous system, passes through an oxygenator and returns back to the venous circulation. It could be used for severe respiratory failure, i.e. ARDS, when the cardiac function is adequate. Conversely, VA ECMO provides both cardiorespiratory support. Blood is drained from the venous system and returned back to the arterial system, bypassing the heart and lungs. It's used for cases of cardiogenic shock, cardiac arrest, or combined cardiorespiratory dysfunction. As we've stated, VV ECMO can be used for the management of respiratory dysfunction. The Extracorporeal Life Support Organisation has clear indications for all management. These include number 1, hypoxemic respiratory failure with a PaO2 FiO2 ratio of less than 80 mm of mercury, after optimal medical management, including a trial of proning. Number 2, hypercapnic respiratory failure with a pH of less than 7.25 despite optimal conventional mechanical respiratory support with a respiratory rate of 35 and a plateau pressure of equal to or less to 30 centimetres of water. And number 3, ventilatory support as a bridge to lung transplantation or primary graft dysfunction. Now we understand that VV ECMO is used for respiratory support. What are the relative contraindications, or what are the reasons not to use it? These include prolonged mechanical ventilation for more than 7 days with a plateau pressure of more than 30 centimetres of water and a high FiO2 of more than 90%, CNS hemorrhage or injury, systemic bleeding or contraindications to anticoagulation, immunosuppression and old age. However, there's no threshold which is currently being established. Now let's discuss VE ECMO. Cardiogenic shock suitable for ECMO is generally characterised by a systemic blood pressure of less than 90 mm of mercury, urine output of less than 30 mL per hour, a lactate over 2 and an SVO2 of less than 60% with an altered state of consciousness, despite optimal management. Short-term mechanical support is considered in patients with refractory cardiogenic shock with a potentially reversible surgical or medical etiology. Medical causes include acute MI, myocarditis, overdose, massive PE, and post-surgical causes, i.e. post-transplantation. So now that we've discussed the indications, let's discuss the contraindications for VE ECMO. Those include poor likelihood of cardiac recovery. There's no ongoing further management options. These include LVAD transplantation. There's severe cardiovascular disease, for example severe AR, and there's other organ dysfunction of the brain, liver, immune and coagulopathy. Also increasing age. So we've now discussed what is ECMO, the different types of ECMO, VA, VV ECMO, and when we should and shouldn't use them. Now let's discuss cannulation. The key terms of cannulation include the drainage cannula, so the cannula which removes blood from the patient into the ECMO circuit, and the return cannula, the cannula returning blood back to the patient. For VV ECMO, the common strategies are threefold. Number 1, femoral jugular, so drainage via the femoral vein and returns via the internal jugular vein. This is the most common. Secondly, you have dual lumen cannulas, so you have a single right internal jugular insertion, draining the SVC, IVC and returning back to the right atrium. And finally, the femoral, so drainage and return via opposite femoral veins. Conversely, for the veno-arterial ECMO, VE ECMO, this can be split into peripheral versus central cannulation. Peripheral cannulation is drainage from the femoral vein and return back to the femoral artery, while central could include drainage from the right atrium and then return to the ascending aorta. Now let's discuss the ECMO circuit. Please note this image is a simplified diagram and the actual composition may vary considerably. As we've described, the venous cannula, the drainage cannula, connects the patient to the ECMO circuit. Within the circuit you have tubing. The tubing is usually made from PVC and is approximately 10 mm in internal diameter, with a length of approximately 4 to 5 meters. The first component is usually a venous saturation meter to assess the saturation of the venous blood. This is followed by some venous sampling ports to sample those venous blood. This is commonly followed by a pre-pump pressure sensor. It's typically a negative value and it indicates the suction required to draw blood from the body. However, a high negative pressure may indicate multiple factors including drainage obstruction, venous collapse or cannula malposition. Now we have the blood pump. This is a key component. It's usually a centrifugal pump. The flow rate in litres per minute directly determines the blood flow through the circuit, which in turn impacts the degree of support to the patient's oxygenation and therefore organ perfusion. Then you have another pressure sensor. This measures the blood pressure after it passes through the pump before going through the oxygenator. It is typically the highest pressure in the ECMO circuit because it represents the pressure needed to push blood through the oxygenator, the tubing and back into the body. And then we have another pressure sensor prior to the oxygenator and then the oxygenator. This is another key component. Within the oxygenator you have a semi-permeable membrane which allows CO2 and O2 to move across from the blood into a gas mixture. We set via the gas blender the gas mixture, i.e. the air-oxygen mixture which is delivered to the oxygenator. The higher the speed of gas flow through the oxygenator, the greater the CO2 clearance. We can also increase the oxygen fraction to increase the oxygen delivery to the patient. The oxygenator may also contain a heat pump to control the temperature of the blood. This is followed by a post-oxygenator pressure sensor used to calculate the pressure across the oxygenator, which is an indicator of the oxygenator health. This could be followed by an arterial saturation monitor and finally a flow sensor and then the inflow cannula. Anticoagulation in ECMO is essential to prevent blood clots. Unfractionated heparin is the most commonly used agent due to the rapid onset, easy titration and reversibility. The activated clotting time ACT is typically maintained between 180 and 220 seconds. This target may vary based on bleeding risk. Now let's discuss oxygen delivery in ECMO. This represents the amount of oxygen transferred from the circuit to the blood per minute. It depends on the ECMO blood flow rate and the difference in oxygen content between the blood entering and leaving the oxygenator. It's important to remember oxygen content. So this is CaO2 equals hemoglobin in grams per deciliter multiplied by 1.39 as each gram of hemoglobin binds 1.39 mils of oxygen multiplied by SaO2, which is arterial oxygen saturation, i.e. the fraction of hemoglobin bound with oxygen, plus 0.034 times by PaO2, which represents the oxygen dissolved in plasma, which is always a small contribution. So in this worked example, the ECMO flow rate is 4 litres per minute, the outlet CaO2 is 200 mils of oxygen per litre, the inlet CaCO2 is 150 mils of oxygen per litre, so the oxygenator adds 200 mils of oxygen every minute to the patient's blood. As we know, ECMO is not without risk and therefore patients can experience complications. These can be categorised into circuit, cannula and patient related. Circuit, these relate to pump, oxygenator and tubing failure. Cannula related could be vascular injury or limb ischemia, and patient related could be hematological, i.e. bleeding, thrombosis, DIC, hemolysis, neurological, stroke, seizures and brain injury, infectious, i.e. pneumonia, and metabolic and organ related, renal, hepatic dysfunction, acidosis, and systemic inflammation. So in summary, ECMO provides a temporary life support in severe respiratory and/or cardiac dysfunction, unresponsive to conventional therapy. Blood is drained, oxygenated and returned to the circuit. In VV ECMO, this supports the lung, whilst VA ECMO supports the heart and lungs. Once again, thank you for watching.